think when Dr. Bang asked me to talk on this subject, frankly, I was not that much aware of that coronary microdysfunction, how much it is as a pathological probably mechanism, maybe and resulting in heart failure with preserved ejection fraction. Now, we know that as far as the magnitude of heart failure, I think is an epidemic, and the heart failure with preserved ejection fraction also, I think in our setup also with aging, the magnitude is rising. Maybe around 40-50% of patients are now with preserved ejection fraction. It's a very heterogeneous pathophysiology, and the coronary microvascular dysfunction, I think, changes in the structure and function of coronary microcirculation in the absence of obstructive coronary artery disease. And does CMD lead to ventricular remodeling, diastolic dysfunction, ventricular stiffness, and preserved ejection fraction failure? I think it's poorly understood, and I will say it represents a major unmet therapeutic need and a gap. The complex molecular and physiological mechanism underlying heart failure with preserved ejection fractions are still poorly understood. The most credited hypothesis proposes that high burden of comorbidities triggering a systemic pro-inflammatory state impairs the physiology of endothelium and subsequently activates complex molecular pathway resulting in myocardial fibrosis and significant stiffening of the ventricle and diastolic dysfunction and HFpEF. Simply, if you look at, I think this try to emphasizes you have inflammation and then coronary microvascular ischemia, of course, impaired coronary flow reserve, cardiomyocyte injury, fibrosis, and diastolic dysfunction, and probably that leads on to the HFpEF issue. Now, just more elaborating on this, which I think my previous speaker have also tried to highlight the comorbidities, whether it is a hypertensive, whether it is a diabetic, aging, obesity. I think probably these situations do initiate a systemic inflammatory state, and that may be affecting the endothelial, resulting endothelial injury, microvascular inflammation, and of course then ROS sort of initiation, and resulting in more vasoconstriction, more stiffness, colonizations, and I think more hypertrophy, stiff heart, and then I think resulting in the situation of heart failure with PEF. The question comes, I think if you look at molecular level, how this goes further is like you have these comorbid states, inflammation, oxidative stress, and which leads to nitrous oxide, some sort of less of nitrous oxide because of the endothelial injury, leading to impaired coronary vasodilatation, impaired sort of muscle contractility, subendocardial ischemia, and that is maybe leading on to the CMD of the coronary microvascular dysfunction, which may be probably some way one of the mechanism of causing HFpEF. I think this was a nice observation which had been published a few years back, that coronary microvascular dysfunction and future risk of HFpEF. Patients who had without any coronary artery disease, impaired CFR was independently associated with diastolic dysfunction and adverse event, especially HFpEF hospitalizations. And if you look at that, the coronary flow reserve, if it is less than 2, probably they are much more prone to develop HFpEF situation as compared to people who have a coronary flow when you estimate more than 2. And I think coronary, and this is again trying to emphasize that univariable model also, or the multivariable model, that 2-3 times higher chances of developing cardiovascular death, myocardial infarction, heart failure, or heart failure preserved ejection fraction if you have a CFR which is less than 2, or you also have a diastolic dysfunction like E over E prime ratio of more than 15. Even this is just to emphasize that the adjusted the freedom from events is also significantly low in patients who have a low CFR. And repeated annulated hospitalization for HFpEF also, again, those who have a low CFR and E over ratio is less than, more than 15. I think these indicate that CMD probably has one of the underlying mechanism, maybe inducing heart failure with preserved ejection fraction. I think how do we measure? We know in the invasive lab you have the intracoronary Doppler wire, I mean you measure by that, but now we have non-invasive ways of doing CFR or what is we call MFR, whether you do PET or by other non-imaging ways, that you can find out the microvascular dysfunction in an individual. And probably that if you study these in these comorbid individuals and you find that the value is low as sort of, then they are the patients may be more prone to HFpEF issue, and then you might be able to take preventive or therapeutic efforts to prevent this kind of situation. Now this was, I think, one first prospective multi-center, multinational study to demonstrate a high prevalence of CMD in HFpEF patients. So about 200 plus patients, mean was 74 age, and patients with unrevascularized macrovascular coronary artery disease were excluded, and CFR was measured with adenosine stress transthoracic Doppler on echocardiography. 75% of the patients had a abnormal CFR that was less than 2.5 by this thing. And 1 year follow-up of this, those who had a low CMD was independently associated with primarily cardiovascular and heart failure specific events, and that it has a prognostic kind of implication or meaning. This is another observation of coronary or CMD in heart failure with preserved ejection fraction, patients who had obstructive coronary artery disease as well as those who have not a significant coronary artery disease, but 85% of the patients who had a HFpEF had low CFR. So some way other CFR, I think, may be underlying mechanism to induce HFpEF kind of situation. And these are just mechanistic unraveling of HFpEF with this associated comorbidities, whether a systemic alteration or cardiac alteration, like inflammation is there in HFpEF, and all these kind of comorbid states, microvascular density, oxidative stress, fibrosis, as kind of underlying pathological processes. So I think as a clinician, why we should really be sort of, that this is one issue which might help us the therapeutic potential if we handle the CMD kind of some way that you improve. I am sure my previous speaker which has highlighted the lifestyle situation, I am sure this may be also affecting the CMD in these patients if you sort of do. So I think number of drugs have been tried affecting these molecular issues, nitrous oxide, like cyclic monophosphate, ranolazine, antifibrotic agents, anti-ILA targeting, relaxin. Of course, we know that like SGLT21, ARNI and MRA, they have now become, at least today we know that these three drugs have a class 2 indication. ARNI is class 2A now and the other is class 2B. That they have some role in patients with high-stall, I mean, apart from we only had up till now diuretics. So these drugs may help the patient with HFpEF, and how they alter these underlying CMD molecular mechanism possibly may be interesting. Like this is a recently published preserved where empagliflozin has been shown to be useful in patients with HFpEF. ARNI again, now if you look at the various, these were other drugs which have been tested, but somehow the other none has stood to their lack of efficacy with these agents, whether we need more studies. But it only emphasizes that our therapeutic options, medically or non-medically, if we try to address to the CMD, you measure it, you try to see how do I follow, maybe good way of monitoring these patients, and we may find some kind of a ranolazine has been evaluated, and this is a meta-analysis indicating that ranolazine may sort of affect coronary microvascular dysfunction and may be useful in these patients. I must share with you that in India, the ICMR has funded a study, and 5 centers are involved in the country which are trying to study Ronella gene in patients with high heart failure with preserved ejection fraction. Of course, I think that summarizing the coronary microvascular dysfunction and the heart failure with preserved ejection fraction, I think these have research implications, these have clinical implications. We need to have the mechanistic issue, therapeutic issue, protection scores. I think then managing based on that knowledge of non-invasive monitoring and trying to assess how these therapy alter that particular parameter. I think this looks to be an important parameter to study in these patients, and also particularly those with comorbid situations to see we can sort of understand more about this entity, and that may help us both in prevention as well as therapeutic approaches. So the microvascular dysfunction is important underlying mechanism for heart failure, preserved ejection fraction. CFR or MFR measurement with non-invasive measures may help to identify phenotype subsets of HFpEF in patients with comorbid condition associated with it, and therapeutic option which modify CMD may help to both prevent and treat these individuals. I think this opens a new option to explore, study drugs based on molecular mechanism of CD, and apart from that, the lifestyle related approaches, I think, which have been emphasized, may also help to sort of improve the CMD and may help to prevent this situation. Thank you so much for your patience hearing.